Hello, everyone. Pro-protein convertase subtolysine kexin, right? I just wonder what happened to types 1 through 8, but anyways. I know it's been a long day. I'll try to make this less, I don't want to say boring than normal, but so my talk is a radial intervention update. I have no disclosures. It's a brief outline. I want to go over the history, rationale, mounting outcomes data. It's very powerful, as you can see. Historical perspective, the guidelines, both in US and Europe, we're lagging a little bit there. Current utilization, patient selection complications, patient operator experience, and a hospital perspective. So, brief history and rationale. The first angiogram from the radial was 1948, very big catheters which prevented ongoing use. In 1989, Dr. Campo, one of the founders of this technique, reported a series of 100 procedures. In 1993, the first stent was placed through the radial. The rationale for the use is that, particularly in ACS patients, antiplatelet and anticoagulant therapies are accelerating. They improve ischemic outcomes, but results in bleeding. Infrequent, but still a problem. We know when people bleed, they do poorly, and transradial interventions reduce access site bleeding, so that's the rationale. Additionally, transradial interventions improve patient comfort and convenience, early ambulation, and reduce costs. So a little data to support that rationale. This is bleeding from the Ncdr, multiple millions of patients analyzed here, different presentations, stable, non-STEMI, and STEMIs. All patients bleed. The more acute the presentation, the more likely the bleeding. The blue and red represent access site and non-access site bleeding. You can see access site bleeding is important in all three groups. This is meta-analysis of bleeding in ACS from 10 studies. Basically, I put this in here to just show. Actually, I don't think I have a pointer that works here. Oh, there it is, sorry. A 7.6 times higher risk of dying if you have significant bleeding with ACS, so a major predictor of a bad outcome. This is similar pooled data that shows that regardless of the type of bleeding, access site or non-access site bleeding, there's still a higher risk of mortality. More pooled data which shows that MI and stroke also are highly correlated with major bleeding with your procedure for ACS. So bleeding is a big deal. It's not a big surprise. This is another meta-analysis that looks at the comparison of transradial and transfemoral and what it does to bleeding, and there's no argument here, 73% reduction in bleeding with transradial. So all the parts of the story make sense, but you know, that's observational. It's not randomized prospective data, which is what we care about. So let's go through that briefly, and that data is becoming overwhelming. So the first big trial was the Radial trial, which is a prospective trial that looked at ACS patients, 7,000 of them. They were randomized to getting their procedure from the wrist or the groin. They looked at ischemic and bleeding outcomes. There was no major difference in this trial, which many transfemoralists thought was positive, but as we'll see, a lot of things came from this that showed a benefit of transradial. When we looked at bleeding in this trial, the definition they used showed no difference, but it was a very, very strict definition. The more accepted definition of bleeding from the QD trial showed a significant reduction in the radial group. Most importantly, however, when they looked at the subgroups, the group of STEMI patients in the trial had much fewer outcomes, poor outcomes in the transradial group, a 2% reduction in the combined endpoint. But more importantly, death was reduced, so a mortality benefit with the transradial intervention. Again, this was subgroup analysis and thought to be hypothesis generating and not confirmative. That led to several randomized studies of STEMI patients, specifically transradial versus transfemoral. This is a STEMI radial trial. The primary endpoint here was a bleeding endpoint, which showed a marked reduction. That's supposed to be 1.4%. I don't know why that didn't show up, but a marked reduction with the transradial procedure. When they looked at the ischemic endpoints, death, MI, and stroke, none of them were significantly different, but there was a trend towards less death in the radial arm. And when they combined the bleeding and the MACE outcomes, obviously, since the bleeding was so overwhelming, there was a significant reduction in the net clinical events. That led to the Rifle trial, which was done in Italy, 1,000 patients, very experienced operators. Again, radial versus femoral. They enrolled everybody. They could be in cardiogenic shock. They have very loose consent rules there. And what they found was their primary endpoints of, struggling with this mouse, of net adverse clinical endpoint events and bleeding were both markedly reduced. In addition, the major adverse clinical events, MI, repeat revascularization, and stroke, were lower in combined fashion with, interestingly, the individual component of death driving that combined endpoint, which was very significant, a 4% reduction, almost so much so that people didn't believe that just going through the wrist would reduce your risk of dying by 4%. But again, all this data was in the same general direction, so it started to become more convincing. This just shows that in that trial, all of the bleeding reduction was access site bleeding, which is what we expected. Most recently, the Matrix trial was published, and this provided a lot of insight into a lot of different areas. It was a complex randomization of STEMI and non-STEMI patients to access site, radial or femoral, the type of anticoagulant they got, and then the duration of the bivalverin treatment. So we'll just look at the access portion, radial versus femoral, two primary endpoints, again, MACE, and net adverse clinical, which is basically MACE plus bleeding at 3 months. They had a pre-specified endpoint, which was even more strict, so they needed a 2.5% error rate, or alpha, which is a 0.025 p-value, which they didn't meet for MACE, although there was a significant trend. And when they did the net adverse clinical events, there was a significant reduction of about 2%, so translating to a number needed to treat about 50. Simultaneously, they published a meta-analysis of all of the randomized data for ACS patients between transradial and transfemoral, and this is very powerful because the numbers are very high, about 20,000 patients, and what they showed was that there was no increase in MI or stroke, yet there was a significant reduction in death, 28% reduction. So this is pretty compelling stuff. It is important to understand that within these trials, the benefits were really only seen in the high centers, high volume centers. So if you see here, this is for the MACE and this is for the NACE. Significant reduction in the high volume centers, but no difference between the two groups in the low and intermediate, meaning that experience matters in this. This was also seen in the Rival trial where the high volume centers had a significant primary outcome. So let's look at some more outcomes data. Specifically for Matrix, they pre-specified an endpoint of kidney injury, as that we also know to be a very important outcome. In this trial, if you look at the top there, the red bar is femoral, the blue bar is radial, and that's acute kidney injury, and there was a significant reduction in the radial arm. Those are just the numbers, 15% versus 17%. Those are different definitions. What they found was that particularly in the sicker patients, those with the starting GFR that was less than 60, those older than 75, an advanced Killip class, or a high predictive score by Dr. Moran. Moran's published a risk score for kidney injury. They derived the most benefit in terms of reduced kidney injury. So how do these outcomes compare? So we'll take a little stroll down memory lane and look at the historical benefits. I don't know, I'm sure some of you were around during this time and some of you weren't, but back in the early, late 90s, I would say, the Augusta investigators looked at TPA versus streptokinase and showed a 1% reduction in mortality using TPA. Then we moved to primary PCI versus lytics, which become the standard of care, as it demonstrated a 1 to 2% reduction in death using primary PCI. Door to balloon times greater than 120 minutes bad, less than 60 minutes excellent, and that conferred about a 50% reduction in death. So therefore we have these systems for timely primary PCI. So major impacts into mortality. How does transradial versus transfemoral fare? Well, about the same. There's about a 2% reduction in mortality. So comparing these these four interventions, equivalent paradigm shifting type numbers, and this is just a strategy change. It doesn't require a new medication or a major change to your operations. So in light of all this data, what do the experts say in terms of guidelines? Well, it's varied. In the United States, ACCH guidelines for just PCI recommend radial as a 2A recommendation with a level of evidence A. 1 means everyone recommends it, 3 means it probably causes harm, don't do it. 2A is most people do it, and most people don't. 2B, most people don't. And the level of evidence is how powerful the data is, and A is the most powerful. So 2A level evidence A. How about for STEMI? They don't give a formal recommendation in America. They just say it should be used when feasible in experienced centers. So very soft wording. As far as radial for other acute coronary syndromes, non-ST elevation MIs, it's not even mentioned at all, which is really concerning given this huge amount of significant data. In Europe, however, they have, I think, appropriately incorporated this data into their guidelines and have given radial the strongest possible recommendation, a class 1 level of evidence A, but they did limit it to experienced centers. Well, what is the current utilization in America? It's better, but it's still not close to good enough. This was a look at 2013, again, the Cath PCI database, about 3 million patients. This was in 2013. There was about a 16% utilization for PCI in America. These are subgroups. Interestingly, the PCI growth was greatest in younger patients less than 75, men over women, those with not ST elevation MI presentations, either stable or non-STEMI. So the STEMI patients lagged in their growth of radial utilization. And then more so in the Northeast compared to other regions. In that same study of that huge database, they looked at outcomes and they basically demonstrated that the procedural success was the same, regardless of age, sex, or PCI indication. But in all subgroups, bleeding complications and vascular complications were reduced. So, these are very powerful conclusions from huge amounts of data. More recently, a few months ago, they published a reevaluation of the Ncdr database in terms of kind of trends of care. They didn't look at the outcomes, but they looked at what people were doing and what they were using, and one of the components of that was how much transradial PCI is there. More contemporary, 2011 to 14, that rate has gone up from about 16% in 2012 up to 25%. So better, but again, not great. And unfortunately, as I alluded to in the 2013 assessment, the radial utilization is in those people actually that are least likely to benefit from it. So this study looked at patients and separated them by their predicted risk of having a femoral complication, bleeding or vascular complication. With all the way on the left are those at lowest risk for a femoral complication, middle is intermediate, and on the right is the highest risk for a femoral complication. And as you can see, the black bar, which is using the femoral, increased despite the increasing predicted risk of a femoral complication. So it should be the opposite of that, obviously. So that goes to patient selection. How do we select this, and how do many people select their patients for this route of angiography and stenting? This looked at factors that can predict failure of transradial PCI. So age over 75, prior CABG, being taller made it easier, so short height. This just showed that the rate of failure increased at 165 or lower centimeters, 5'5". This was a trial that looked at a scoring system, and they concluded that female sex, a prior CABG operation, or presenting with shock with a point system increased the probability of transradial failure. So it's very important to choose wisely, and I think this is laid out in this framework where when you start doing this procedure and you have less experience, you should do it on easier patients, men less than 70 with good pulses, and then it kind of escalates as the complexity escalates. What about complications? Radial artery occlusion is something that people worry about. It's actually asymptomatic. Here's a picture of the occluded radial. We know it's related to sheath size. We used to use 7 French sheaths, but equipment's getting better, so we can use smaller sheaths. This is a picture of something called the glide sheath slender. You can see the middle, they just basically thin the wall of the sheath, so the inner lumen's the same as the 6 French on the left, and the outer lumen is the same as the 5 French there. That's helped quite a bit. Full anticoagulation, we used to think intermediate heparin was sufficient, but there were still high rates of occlusion compared to full anticoagulation, so that's critical. If people are on warfarin, that's not sufficient. Even if they have therapeutic INRs when they get their procedure, they still need additional heparin. This is something called Payton Hemostasis, which many of you probably have heard of. It's important that we don't occlude the artery when we compress it. This was a study. They put a manometer on the TR band, which measures the pressure up against the radial after the procedure. One group got pressure just at the map, the other got it twice the map, and those that had significant pressure or occlusive pressure had a much higher risk of radial artery occlusion. So we know the radial artery has to be open to stay open. That's not practical. This is more practical. This is called the reverse Barbeau test. So with the TR band achieving hemostasis, we occlude the ulnar, and we make sure the waveform in the thumb does not go away, meaning the radial still has to be patent despite the presence of hemostasis. So Payton Hemostasis in the blue showed much less radial artery occlusion compared to a traditional compressive hold. Spasm is another big deal. It's usually preventable, good sedation, analgesia, sheath types, vasodilators. It's most common in younger women who aren't sedated well. Here's a picture of pre and post verapamil. It's very sensitive to vasodilators, so it's very treatable and preventable. This is an IVUS image of the same artery, how big it can get with proper vasodilatation. There's no benefit of long sheaths, and you really want to optimize or minimize the sheath size. If in the most severe cases, catheters can get stuck, and you may need to do more significant anesthesia to get it out. The best solution is prevention. If not, wait a long time. Again, pain control, and then potentially stick proximal if it's an access issue, or ultimately switch to the other arm. Another major complication we worry about is perforations. There's multiple small branches, unlike the femoral, so you have to know in the cath labs you're working that this is possible. More common in the elderly, have frail vessels and tortuous vessels. Still uncommon, less than 1%, a lot of anatomical variance. It can lead to hematoma. This is a grading scale. This is a good card to have up in the lab. It shows different treatments of the different levels of hematoma. Extreme cases, compartment syndrome. If there's severe, severe pain, that needs to be addressed immediately, often with vascular surgery, but again, fortunately, this is quite rare. What about the patient experience? Ultimately, we're in a service industry, and we want our patients to be well cared for and happy. This is an old study of quality of life measures, multiple different measures. The white is radial, the black is or opposite of that. The black is radial, the white is femoral, but improved function, social function, pain scores, et cetera. In that rival trial, they asked the patients randomized to transradial and transfemoral, would they want the same procedure through the same route? 90% of the radial patients wanted it the same way, and only 50% of the femoral patients. And remember, 50% didn't have complications, so despite those that didn't have complications, many of them did not appreciate the experience. I mean, on top of the fact they were having a heart attack. So what about the operator experience? This is probably a big reason the uptake hasn't been great. Operators, I know this is a struggle in our lab. Some don't like the extra time it may take, radiation exposure and comfort. These are all solvable and get better with time. This shows the fluoroscopy time with more experience, and it really decreases and levels off after the first 50 cases, so that's the learning curve. This looks at radial proficiency and radiation exposure from the rival trial, and it was really only in the low center volume and low operator volume was there a difference in the radiation exposure. That's been slightly debunked in the radiation matrix trial. They looked at radiation in that randomized trial, and there was slightly higher radiation at the thorax for the operator, but and there was no difference between right or left radial. I'll slip through this, I'm running out of time here. But ultimately, it's about good radiation habits. And for those of you that are in the lab directly, you know it's important that whoever's operating the pedal do these things. There was a paper published on these practices, avoid fluoroing up the arm, doing fluorosaving instead of cine, using the left radial when possible, as there may be some lower risk there. So it's really more about the operator, and low femoral operator radiation users tend to be low radial operator radiation users. So it's less the access than it is the habits of the operator. So operator discomfort, this is real. It's harder to do left radials, much more discomfort, but with practice, like anything, it gets better. I'm in the sum up point of view, which I think I'm pretty close to on time now. What about the hospital perspective? Well, the bean counters care about money and length of stays, and you guys all know about this. Some people here, not naming names. This study looked at transradial versus transfemoral, 7,000 PCIs, 5 hospitals, and in all patients, it was about a 0.4 day decrease in length of stay, which is really, really significant in terms of staff hours, throughput, bed availability, et cetera. When they looked at the dollar amounts, it was an average of $830, and those that were at the highest risk to having bleeding problems, they saved $1,600 per PCI, so kind of a big deal. So in summary, transradial makes sense. It's good for the patient. It's good for the staff and the doctor, mostly in that you feel satisfied that you're doing what you believe is right for the patient at the cost of slightly higher radiation. And ultimately, it's good for the hospital. So hopefully you guys can advocate and increase that 25%. So next year we're talking 50% range or something. All right, thank you.